Okay, so hello everyone, and namaste, and very warm evening. Good evening to you all. I, Kapil Gautam, welcome you all to this 114th session of Mero Eye Talks webinar. Today, as a speaker, we have Dr. Jasleen Kaur, and she will be talking on the topic importance of optometry in multidisciplinary research. Before she begins, I like to give a short introduction. Dr. Jasleen is a senior clinical research fellow at Northfield Department Clinical Neuroscience in University of Oxford. I welcome you, Dr. Jasleen, on the behalf of Mero Eye Foundation and all the participants. So now it's over to you, Doctor. Please proceed.
Thank you. Thank you so much for the invite. Namaste, pranam, sat sri akal to all of you. I thank you for that kind introduction. So what I want to talk to you today is about how to get involved in research, what are the different types of clinical research you can do, and show you some examples from my own work as to how I've made that happen. So I'm going to go through why it's so important to get involved in research, so diversity in research, the difference between a clinical trial and clinical study, how to choose the right outcome measures, and raising the profile of optometry in multidisciplinary research, and then how to set up clinical research. So a lot of research is very Western orientated. And we know that that's not always applicable to all other nationalities because, for example, in genetics, we know that there are different diseases that are prevalent in different parts of the world, and risk factors change based on genetics. So there's definitely the need for more research in other populations other than European. And we also know that cultural differences occur across nations. I mean, having grown up between two cultures myself, I felt that during my own lifetime. And that can influence how you interact with the patients, which interventions are going to be acceptable. I know that equipment varies between countries. Having worked in 5 different countries as an optometrist, I'm very conscious of how some places don't have as much equipment available as we do in the UK. And then training differs. So optometry seems to be very, very different between countries, and what you can do, what you're allowed to do, changes incredibly. So I hope this shows you why it's so important for people from South Asia to get involved in research. And I would encourage each and every one of you to try and do some level of research. And hopefully I will show you today that it's quite easy to do some basic clinical studies with your patients as they come into your clinics, and getting your names and your perspectives into the literature is really important to raising the profile of the needs of Asian people. There are 2 types of clinical research. One is a clinical trial and the other is a clinical study. A clinical trial is basically interventional. So whether that be pill, medication, operation, exercise, counseling, yoga, all sorts of things, anything that changes is aiming to change the clinical outcome in that patient is named an intervention. If you are just observing the patients, then that is known as a clinical study. And clinical studies are actually really important to support clinical trials, which I'll go on to show. So clinical trials are the ones that always come in the news, but in order to make a clinical trial successful, a huge amount of work has to go on in the background. via clinical studies. And that's where optometrists can really shine for visual related clinical trials, because we have the tools and the knowledge to be able to really hone in on assessing the visual system. There are several stages in research, and this whole pipeline can easily take 10 years or more. So the preclinical work is the laboratory-based studies to design any intervention. Then you need to do optimization of the outcome measures, and this is often done at the same time as the clinical trials, though in an ideal world it should be done before. Then the results go to the regulatory authorities, who have to review all the data, say, yes, this is safe and effective, therefore you can use it in human patients. And then depending on which country you're in, the funding of the healthcare system is different. So in many countries, it's insurance. In the UK, we're very lucky to have the National Health Service and NICE, our body, who review the information and decide whether that treatment will be available to patients on the NHS. And then finally funding is agreed, and that's when it becomes available to patients. So this is quite a long journey. And even within clinical trials, there are multiple stages. So a phase 1 trial is a small group, sometimes in healthy volunteers, but it depends on the condition you're investigating as to what's feasible. And the main purpose of a phase 1 trial is to check the safety and side effects of your treatment. A phase 2 trial is a much larger group, and the aim of this is to check effectiveness. So you can have different populations, and you're watching them over time to see how they respond. Ideally, this needs to be randomized, so you have a strong control group. Phase 3 is a much larger trial, usually international, and this is a great opportunity to start getting into this kind of work for you guys, because you can approach companies and offer to host their research, and they do all the background work for you, and then you recruit and assess the patients. So it's a lot less work than setting up your own studies. The phase 3 trials usually use the commercialized product. So in gene therapy, which is one of the fields that I work in, for example, for phase 1 and 2, we had a special research grade vector that was created for us in a laboratory in America. But then for the phase 3, we have to use the final product. So so it comes from a factory that is going to produce the final product. And that's to make sure that what is eventually going to be sold on to be used in patients has the same effects as the research grade vector. So, and then also you can look at different populations, different dosages. You need up to phase 3 to get approval for use of that intervention in a clinical population. And then phase 4 is post-approval. So phase 4 can happen anytime, even years later, when the drug or whatever it is being used in patients. And it might be to try it out in a different population of patients, for example, as happens with a lot of drugs. So other similar conditions can be tested out to see whether there's any advantage in those populations. It might be looking at different age groups, different disease severities. So there's lots of scope. So that shows you why clinical trials are important, but clinical studies, I think, are too often ignored. A large proportion of clinical trials actually fail at the phase 1 stage. Almost half of them are reported in the literature to be due to lack of effectivity. So this can include a number of reasons, but some of these that can be corrected in clinical studies are poor feasibility of the testing procedure, poor repeatability because the individuals haven't been trained and their procedures haven't been standardized well enough, difficulties with recruitment, inappropriate choice of outcome measures because people have used just what's available rather than what would best reflect the disease process, incorrect interpretation of the results, so using either statistics or actually analysis methods that are not really appropriate. And then quite often there's too much emphasis on what's statistically significant, but we need to establish what's clinically significant. So if something isn't really going to make a change to patient quality of life, if you have thousands of people enrolled in a clinical trial, you'll likely get it's easier to get to statistical significance. But if your change is less than the repeatability of that technique, so repeatability is when you do things once, do things twice, and how much difference you can get, then that's not a clinical significance. So I always try and comment in my work on both just statistical significance and also clinical significance. A while ago, I did a review of outcome measures used in gene therapy specifically. And because trials have to be registered and they label what tests they're going to use beforehand, I compared back against what was in the final papers with what they had said they were going to do. And a huge number of trials use a lot of additional measures that they didn't originally factor in to their analysis. And I think when you do clinical studies in advance, you're able to whittle this down. So by the time you get to the clinical trial, you're only using what's pertinent. So clinical studies are really important to validate measures in a clinical population. So a test might have been developed, but it might be for a different disease group or only have been tested in healthy participants. If you want to check how well it works in your specific disease group, then a clinical study is going to answer that. We can look at feasibility of conduct. So for our disease group, do we need to make any changes to the test procedure in order to make it easier for the patients to actually be able to do the test? And I'm going to show examples of this a bit later on. But also we're running a study in Usher syndrome, which is retinitis pigmentosa plus hearing impairment. So the patients have both hearing and vision loss, and especially techniques that we have to do in a dark room, for example, we can't rely on the patients hearing our voices. So we have to change the test procedure, and we can really improve how we do things within a clinical study to make sure it's going to work as best as it can do. And the better the technique works, the better the data you get and the more believable the results of that clinical trial are going to be. We can assess repeatability, and repeatability does change in different populations. So with visual field, we know that they are more variable in low vision populations, for example. So I always try and assess repeatability of the tests that are most important in each of the populations that we're then going to go on and study. It allows us to review recruitment. We can engage with patients, get them excited about the research. I also, because I interact with my patients in the clinic, they already know me. I use that to help recruit to the studies, and because they know me and trust me, then they're more likely to actually get involved, whether that's a clinical study or a clinical trial. And if they've taken part in the clinical studies, then they're invested in understanding the outcome. So then you can recruit them into the clinical trials. Research has also shown that places that are active in research have a higher standard of care for patients. This is partly because they understand the latest developments and are able to implement them within the patient care. But also the patients often feel better looked after. They're able to interact with you in a more detailed way, and they really appreciate that. And they have this perception that that they are getting better care, which often is true. So being research active is actually really helpful to your practice. it can help by talking to the patients. We can establish what is important to the patients. So using some of the outcome measures to reflect the things that the patients notice and that the patients really affect their quality of life is going to help with getting approvals for that therapy. We need to look at natural disease progression, because if you don't understand how the disease changes over time, then how do you know whether your therapy is actually changing the course of the condition? So having natural disease progression studies beforehand is really useful tool to compare back, and it can shorten the length of the clinical trials. And since clinical studies are cheaper to run than clinical trials, this makes the clinical trial more effective, more cost efficient, and quicker. And also, I'm going to show you examples of how doing the clinical studies has changed clinical practice and allowed me to issue new guidance and others. And so it's not like research is just research and clinical work is just clinical work. The two do interact. So how do you choose an outcome measure? Because we've already discussed like the importance of getting the right way of measuring your therapy. You can have the best therapy in the world, but if you're not choosing the right way of measuring it, you're never going to be able to prove that it actually works. So the first thing I would say is listen to patients. Listen to what they're saying, what impact the disease has on them, what aspects of the vision loss are important to them. Also psychological aspects as well. So I've got a study going on at the moment, which is looking at how the thinking patterns in people change after they've lost their vision, so that we can help them cope better. You need to make sure whatever you're using is repeatable. If the technique is too variable, then you need a large change in order to effectively pick up any clinical change in that measure. So having better repeatability, which can often be improved with your training and the way you do the technique, is beneficial. Look at how long it takes to do the testing, because you don't want to overburden the patients. And so for the gene therapy trial, for example, for some visits, I have patients coming in for 3 days to do tests, and that's exhausting for them. And this is always a bit of a balance, because say with psychophysics, for example, whether that be color vision testing, contrast sensitivity, you know, or visual field, you're going up and down in the threshold range, and you're trying to determine what the final threshold is. The more times you cross the actual threshold, the more accurate result is going to be. But the more times you do that, the longer it takes. So with clinical work, sometimes compared to basic science research, we need to make some modifications, and we need to have a bit of a compromise to balance the time taken versus the scientific rigor, and try and find a good compromise that works on both levels. And then, of course, it's worth considering what the regulatory authorities require. So the FDA is the regulatory authority for America, which is the agency always on the news. In Europe, we have the EMA. In the UK, we have the MHRA. I'm not sure what the system is in Asia, but they often have tests they will accept the outcome of and tests they won't accept the outcome of. So one of the piece of work I'm trying to work on now is how to better work with the regulatory authorities so that any new measures get approved by them and accepted by them, and what do I need to do to make that happen. And then we also want to really understand what's driving that outcome measure, like what are we actually measuring. So this image here is an example of a microperimetry plot. So microperimetry is a type of visual field analysis, also known as fundus control perimetry. And the machine has an eye tracker installed in it. So during the visual field test, we're able to track the eye movements and to some degree compensate for that. So it's supposed to give very accurate measurements. The light is projected directly onto the retina, so it's a measure of retinal sensitivity. And what I've done here is put the visual field against a background of the imaging. This is autofluorescence imaging, which is conducted on some OCT machines, so that we can identify what part of the pathology is being reflected in the sensitivity loss. And it's worth comparing your outcome measures to established tests, to structural measurements, to other tests, to really try and understand what you're learning from that. And this process not only helps with determining the outcome measure, but it helps provide information about the disease process, which then feeds back into clinical care and low vision care. So everything is interlinked. Because I work in genetics, another thing that I'm trying to work on is eventually I want to be able to look at the gene defect where it's functioning. So these are lists of genes, and the position of them shows at what point they're working. So these genes, for example, function in the outer segment of both rods and cones. These ones are just in rods in the outer segment. And then these genes affect the retinal pigment epithelium, for example. And eventually it would be really nice to be able to look at the gene and, by knowing where it works, be able to identify which markers are going to be the best to use in clinical trials. You also need to consider the actual intervention. So this is a video from live gene therapy surgery. So you can see the needle here. And the images on the side here are intraoperative OCT. So what's happening here is the retina is being lifted up, so we can insert the gene vector, which contains the healthy copy of the gene, and then the retina gets flattened again, and then the gene gets taken up by the cells, and the new protein is produced to prevent further vision loss. But by looking at how the retina is behaving during this process, it helps to understand what parts of retinal function we need to explore, and also how the surgery needs to be affected to make it, to reduce the risk of any complications. So I'm going to show you examples of how all of these have worked, and the clinical studies that have been done to improve things in a disease called choroideremia. So it's a rod cone dystrophy similar to retinitis pigmentosa. What you're seeing in these fundus images, the pale areas are where the retina has died off and the central part is preserved. So that's still working tissue. So in these patients, you get a progressive loss of the peripheral visual field to end in tunnel vision, and then eventually that might go. And we used to think that the central part was completely healthy. We've now realized that's not exactly the case. There are changes in the center as well. So a key assessment we use in the gene therapy trials is microperimetry, which is assessment of the retinal function. This is a typical plot from the microperimetry machine. So you've got the SLO image here, so the scanning laser ophthalmoscope image, and then overlaid with the retinal sensitivity points that are measured, where green is normal, red is reduced sensitivity, and black is the spots were not seen. We also monitor fixation down here, and you can see that this patient had excellent fixation. So that result is reliable to use. So what we realized, though, is different centers were doing the microperimetry test in different ways. So because this is retinal sensitivity, it's more sensitive than the standard visual field. The original thinking was that it's a reflection of a mixed rod cone response. And if that's the case, then dark adapting the patients for a short while will give you more accurate measure than not dark adapting. So we actually tested this, and we did a study specifically to look at whether dark adaptation affects the sensitivity. It doesn't. This is primarily a cone response, is what we've learned. And that means that we don't have to unnecessarily leave patients in the dark for 15, 20 minutes. We can do the test unless they've just had ophthalmoscopy, slit lamp exam, or imaging, which is a really bright light in the eye. Then they need recovery time, is what we showed. With traditional perimetry, it's been shown that dilation can affect your results. So dilating for doing Humphrey visual fields, for example, will reduce the accuracy of those field plots. Microperimetry, because it works in a different way, in theory, that shouldn't be the case. So we then did a study to make sure that was the actual scenario. And what we're seeing here is that the changes post-dilation are very random. So there's no systematic effect of dilating, and whether you see the patients dilated or undilated doesn't really matter. We just advise that you maintain consistency. So that means that then you can change the order of testing to suit what works with the flow of the other assessments as well. So that's two big questions that were answered in order to make the microperimetry more accurate and more robust, which is going to give better results in the clinical trials. We also looked at repeatability of this in the choroideremia population, and we also looked at the pattern of loss. So this is a composite of 100 eyes. And what I've done here is I've shown the green is where you get maximum preservation, and red is where fewer eyes have surviving retina. And you can see that in the temporal edge here, you get better preservation than you get nasally. So what we were able to do with this information is develop theories about what's causing the progression in the visual loss. Is it related to the underlying blood supply, or the where the rods are more concentrated? And we were also able to use that information to feed back to the surgeon. So when they do the gene therapy surgery, they know to go in from the the temporal side in order to start with the retina that's more robust and reduce the possible impact of complications. So you can, and then I can also instruct patients, which side do they look at to make their life easier, and how that can impact on reading strategies. So you can see that the clinical trial, the actual treatment, and the clinical work all intersects with this work. We also looked at how the microperimetry results relate to imaging. So the blue images here are the preserved retina that was visible on autofluorescence imaging. And we looked, so this is the natural history. You can see the progression over time, and we were able to measure the rate of progression in both structure and function. So you get a more complete picture of the disease. And then in the phase 3 trials, because we already have that natural history, they then know whether the changes are observed are slower, faster, or the same as the natural history. Okay, so that's visual field. Visual acuity is our most basic visual assessment. We do it all the time. It's simple, right? Wrong. Actually, visual acuity is not quite as simple as you see. So this is a simulation of a patient with retinitis pigmentosa or choroideremia. This is how their vision progresses. And what happens is when they're reading the visual acuity chart, they lose their place. So the patients with the more severe disease, we noticed, had higher variability in those measures. So 2 lines is considered to be clinically significant traditionally, but in these patients, sometimes we got more than that in just for variability. And you can see in the simulation here, It's because they're struggling to see across the lines. So what we then did is explored the use of an electronic chart to see if that made it easier. And for some patients, those with macular loss, it did make it easier for them to keep their place. So this strategy helps the most severe cases because it removes the localization element of the visual acuity measurement. We're actually getting a more a true reflection of what the eye's capability is. What about patients who have preserved visual acuity? We can't improve that any further, so there need to be other more sensitive markers. So another thing we've explored is the use of low luminance visual acuity. So this uses a 2-density log filter in front of the chart, which simulates the low light conditions in which the patients have the most difficulty, and therefore it picks out what's happening with the disease much earlier, because you get bigger changes in low luminance acuity than you do in standard visual acuity. And again, we're working on trying to standardize the best way to perform this measurement, so standardize the lighting, the filter. So we've got a student working on a project with us at the moment, and also to get normative ranges of the difference between standard visual acuity and low luminance. What about the other end of the scale? If you've got patients with very low vision and they can't actually see the charts, we explored the use of 2 tests that are commercially available. One is the BRVT, the Berkeley Rudimentary Vision Test, and the other is the FRACT. The BRVT is a set of cards as demonstrated here, and the patients look at the direction of the E. If they can't see the E, we go on to the gratings, and then the black-white discrimination. And the FRACT does a similar thing with the E, but is based on a computer screen and is free to download. And we were able to actually quantify vision right down to almost light perception, which is really important, because from the difference between someone who can read the chart 1 meter versus counting fingers versus hand movements is huge in terms of quality of life. So both clinically and also in research, we need to be able to tell the difference between those grades so we can support those patients better. We can also look at near visual acuity. So in this work, because in choroideremia you get these nice, neat islands on the autofluorescence imaging, we're able to look to try and figure out how much retina do you actually need preserved in order to be able to read. So in this demonstration, this patient in the middle was able to read that letter E because the letter E fits entirely within their island. This patient here was unable to read anything because of the shape of the island. No letters fit in that. So you need to be able to actually fit in within the retinal availability. And in low vision, we often encourage magnification, but actually maybe that's not the best strategy in rod cone dystrophies, where you're losing your vision and you're getting these little islands. So if you look at reading speed and reading size, the acuity of reading, this is a normal plot on the left, and this is one of the patients on the right, and you can see that what's comfortable for them is shifted. So by looking at both factors, we can actually optimize the magnification for that patient. So this is a great example of how research from a clinical study for a clinical trial has ended up influencing low vision care. We also looked at the direction of preservation of the island and found that there was no difference in reading ability. And this is really important because then we can combine results from different countries that have different reading direction of print without any problems. And that's both vertically and horizontally. And we've gone through a similar process in contrast sensitivity, in night vision, in color vision, where we've looked at all these different aspects and tried to really understand what we're looking at and which are the best measures to then use. The next stage to decide is, how do you measure the outcome of your research? So this is a video showing a Goldman visual field, and it's using kinetic perimetry to measure the absolute extent of your visual field. So you're able to go into the far periphery. This was for another study I did, not gene therapy, but another interventional trial. And traditionally, you can look at the individual light levels. So the different isopters are related to different light intensities. But what we've done here is, rather than looking at each individual light intensity, is to combine them into a 3D measurement of volume, which has been more helpful because that gives you an idea of the actual hill of vision and the depth of vision. But which one you use depends on your research question. So sometimes one is more appropriate and sometimes the other. From there, I've gone on to then look at what's happening at a biological level. So here we've got an OCT scan and this is in a normal eye, but in RPGR, which is another form of retinitis pigmentosa, which affects just the photoreceptors. I've looked at what's happening in the inner retinal circuitry, because in lab-based research, what they've shown is that when you get photoreceptor loss, it changes how the ganglion cells and the bipolar cells function, and the neural circuitry rewires itself. Bipolar cells especially change how they connect to the photoreceptors. And we can actually pick this up on OCT. So in the mild disease, what you're seeing here is an increase in the thickness, even though you've got a decrease in thickness in the photoreceptor complex. And if you measure just total thickness, you're going to miss those subtle effects. So you always need to measure the thickness of the layers that you're actually interested in, and not just total thickness of the retina, because in the early stages, these two changes actually cancel each other out. And this can have implications for the function of those patients as well. And that's the next step that I'm now exploring. And a lot of my new research is in neuroscience, where I'm looking not just at what's happening in the retina, but further along in the visual system in the brain, along the optic radiations, to understand how photoreceptor disease can potentially cause these secondary effects which impact on the patient. And that might explain why some patients adapt to vision loss better than others. So within the strands of my research, gene therapy, neuroscience, psychology, you can see that I've worked with a huge number of different professionals. And by working with them, they respect our abilities better. But also we can share expertise. I love collaborating, and I'm a very collaborative person, because I feel when you bring different skill sets together, you actually achieve so much more than you can when you're on your own. And this list is going to expand as my research fields expand and I move into other areas, because as I said, when you put skills together and advise each other on different aspects, then your research is going to be so much stronger. So how do you do clinical research? Well, the first thing is to come up with your idea. So you need to formulate quite a precise research question to do good research. Then it's worth doing a review of the literature. Has it already been answered? If it has, is it in a population that's relevant to you? So what was the ethnicity of the participants? Then you need to decide how you're going to do the research. So which outcome measures are you going to explore, and how are you going to go on and analyze them? What techniques are you going to use? Then you write a clinical trial protocol. So this is required for obtaining ethical approval to do the study or the trial, but it's really good practice to do it even when ethical approval isn't needed, because it helps you really put together the background of what you're doing, formulate the question, what tests are you using, what statistics are you using, who are you going to include, who are you going to exclude, and it makes you think through all the steps. And if anyone would like support with writing a protocol, then I'm happy to send you one of my previous ones as a sample, so you can see the detail that goes into that. Then I write standard operating procedures. So these are step-by-step guides as to how you're going to do your technique. Are you going to, so how do you switch on the machine? How do you set up the patient? How do you input the data? How do you actually then do the tests? What checks need to be included during the process? How are you going to download the data? By having all these steps, it means that you're always going to be consistent in how you collect that information, which is really important for ensuring you get the highest quality of data. Also, even if you've got multiple people, then everyone's working together. And my first research job was in Australia, where we were grading the redness of people's eyes because it was a contact lens research. And we would spend months making sure we were the same. So if you don't do things the same, you can't compare. Even if you're the only person that's going to be doing the procedures and collecting the data, you never know when there's going to be an emergency and someone else has to step in and take over. So if the SOPs are there and ready, then it's easy for them to pick that up. And then if it's a clinical trial, it's necessary to register it on a national, international database such as clinicaltrials.gov. And this means that all research is accountable and that research has to be published even if it's a negative result. And this is quite critical because it stops unsuccessful research being repeated unnecessarily. So just to sum up, clinical academia is a great career choice. It's so satisfying to make a difference to the patients, to set the future standard of healthcare, and also to be able to understand better what's going on and delve deeper into what's happening in the eye and how that's affecting vision. Both clinical trials and clinical studies are equally vital. And clinical studies are easy to set up in your practice, cost much less money. So I really would encourage people to get involved in that and get working on that. Preparation and standardization are the key to collecting high quality data. And the higher quality the data, the better your outcomes are going to be. Clinical and trial work support each other, as I've shown, and don't be, even though you are the expert, don't be afraid to be inspired by your patients. They are the experts on their disease because they have to live with it day in, day out. And there've been a couple of times where someone's made a comment to me which has changed the direction of my research because I've realized that something was a problem that I didn't realize before. So these are all my funding bodies over the last 8-9 years. And of course, I couldn't do this work without having lots of people to work with, both in Oxford and around the world. And I'm always happy to work together with other people if they've got a good idea. And then, of course, my students who I've supervised over the years as well. You know, this is probably a fraction of the people. So the more people you work with, the more ideas you will generate. With that, I'm going to stop there, and I'm really sorry. I think I've gone over my time, and I'm happy to take questions.
Okay. Thank you so much, Doctor, for this wonderful session. It's really making inspired to me. Hope it does to all the audience. So I'm moving towards the next round. That's the discussion round. Let me check the question that's raised by our attendees. I'm going from the bottom. I'm going to pick the question from the Pradeep. He is asking for, is retinal prosthesis helping RP patient?
So there are several types of bionic eyes, retinal prosthesis. Some of them have been working better than others. Some of the programs have shut down now, and some are still being developed. So yes, there is some evidence for some of them providing help, but not all of the different types. And this is why it's useful to have multiple different theories that you can then test out, because you never know what's going to work. But also the research that has come out of the retinal, the so the work we did in Oxford, because it's patients with really low vision, I think that's going to help with other research in the
Dr. Jasleen?
future. So optogenetics is when you manipulate rhythm, so your sleep-wake cycle. So the research there is that we've learned is going to. Oh, hello, can you hear me? Sorry, my
Yes,
internet went off.
yes, yes, ma'am. So please, ma'am, just it's pause in
Yeah,
between.
so the
You can continue. Yeah.
yeah, so the research that's come out of the retinal prosthesis might help these biological therapies, which are going to be more permanent anyway.
Okay, doctor, thank you. So there is another question. So as you told that only remaining cells helps to remaining cells helps to be again for the use. So to measure that, which visual field is more good? Like, would you prefer for static or dynamic?
It depends on what you're looking at. So when we're looking at the center in great detail, my preferred choice is microperimetry, and that's a static. Kinetic is really useful when you want to look at the absolute extent of the field, so screening the peripheral regions. In that case, I prefer kinetic because you have so much flexibility over the areas you're testing and how you're testing them. And it's a bit quicker than doing a very wide field with static stimuli. So, but it really depends on the research question, because we've also looked at patterns of the peripheral loss, because in a lot of RPs, you end up getting these very far peripheral islands that people are still able to use to navigate. And for those, we've used the Octopus, which is the computerized version of the Goldman perimeter, and that's using static. And then we've been able to look at the preservation on the temporal side versus the nasal side. So it really, really depends on what you're trying to investigate.
Okay, thank you so much, ma'am. There is another question from the Srijana. So she's asking for, does gene therapy can resolve the normal visual field, or it just preserve only what is left?
The main aim of it is to preserve what is left. There are some situations, so with some of our patients, we have noticed an improvement in vision. That's about 20% of patients across the gene therapy trials. And the reason for that is because as the cells are dying, it's not like they're alive and then they're dead. They have a whole degenerative process. So if we get there in time that we're able to rescue these cells that are on that decline, then we might be able to actually improve the function of those cells. But if that happens, it's a bonus. The main aim is really to preserve what's remaining. Stem cell therapy in the future will actually be able to to regenerate the cells, but at the moment, I don't think that's really ready for human clinical trials.
Okay, thank you so much, doctor. So there is one question from our team member. So is it possible to treat the cases of retinal pigmentosa with the gene treatment in the near future? What is your intake on that?
So the first gene therapy is already approved and is already being used as a treatment. So that's for Leber's congenital amaurosis. And we're hoping our treatment for choroideremia will be next. And there are loads of others that are being tried all around the world. Even Saudi Arabia has a trial going on MERTK, which is another form of RP, which is prevalent there. So yes, gene therapy is definitely the future, and it will be coming into patient care. It already is coming into patient care.
Thank you so much, doctor. There is another question from the Sylvia, and she is asking for, does those gene therapy could resolve and restore the defect regardless of the ocular disease, or just prevent the remaining vision left?
Yeah, the gene therapy mainly protects the remaining vision. yeah, for restoration, you really need to regrow the cells, which is the domain of stem cell therapy.
Okay, doctor. So there is another question from the Azad. Is there any role of gene therapy for amblyopia?
No, because amblyopia is not from cell loss. Amblyopia is so when you're born with poor vision, and that gradually improves over time. So within the first 5 years is when you get the most changes in the visual system, and you need to have stimuli in order to develop that system. Because if you have a squint or high refractive area in one eye compared to the other, then you're not going to get the same level of visual stimuli, and that's what causes amblyopia. So it's a disease of the development of the visual system. There are ways, so I am one of my colleagues in the Neuroscience Center is actually studying amblyopia in a lot more detail, and looking at ways of improving amblyopia, but the mainstay of therapy is patching and just using the eye. We're thinking about investigating the use of computer games to encourage people to use that eye, particularly with virtual reality. And some studies have actually shown that the brain is more plastic than we originally thought. So if you lose vision in one eye, then the amblyopic eye can actually improve, and we can treat amblyopia in some patients even into their teenage years. So there's a lot of work going around that, but it won't be gene therapy because it's all about the neural circuitry.
Okay, thank you so much, doctor. And these were the only questions so far. So we are waiting for a few minutes if anybody wants to ask a question.
Another piece of advice I can give is if you're interested in a particular research topic, it's worth reaching out to people who are working in that field if you need help and advice and you can't find a mentor locally, because many of us are always happy to support and advise other people. So if there's a particular field you're interested in, just have a look at who's publishing papers in that area, who's giving talks in that area, and don't be shy about reaching out to them.
Yes, true. And thank you so much for your advice. And I guess this will help for most of the young optometrists. So I guess we are about to end up the session. So if anybody have the question or wants to connect with ma'am, I'll be dropping the Gmail, or you can also connect with ma'am. And ma'am, do you want to give any good notes before ending or wrap up the today's session?
Well, so thank you for all your questions and for attending today and engaging with the conversation. And I wish you all luck, and I hope to see lots of research coming out of Nepal in the future.
Thank you so much, ma'am. So herewith, I announce the close of today's session. Still, if you have any queries, we have a different group, either in WhatsApp or Messenger. You can drop. I'll be reach out this question to the Jasleen ma'am. So once again, thank you so much, everyone. Stay safe. And herewith, I close the today's session. Thank you so much. Thank you, ma'am.